this would be the outline of the lecture. We will look at the concept of precision medicine, pharmacogenomics, and how do you translate the genetic variation to clinical effects, the actionable genotype, criteria for drug relevant for pharmacogenomic service, and challenges. Okay. But first, let us look at the current scenario. Okay, current scenario is that when you are dealing with medication that are being prescribed to the patient, usually the dose of that medication or the type of that medication that are given to the patient are based on the clinical trial. Okay, so in the clinical trial, they will have a few steps. So towards the end of the step, like the clinical trial phase 3 and phase 4, phase 3, for example, they will have a group of patients with the disease, and then they will test whether the drug is efficacious or not, meaning giving the effect or not, and what would be the dose. Okay, whether it's 20 milligram one time daily or 2 milligram 2 time daily. So that would be the dose that are given or tested to the patient during the clinical trial. And based on this clinical trial result, they will determine what is the best dose. But the number of patients that they have in the clinical trial is very limited. Okay, and then they are just they determine the dose based on that certain group number of patient only. And then once the drug has been marketed, everyone, all the patients that are being given this drug, they use the same standard dose. Okay, so what happened is, throughout the years, after a few years of use and then using the same dose, we follow up the patient, right? Because we want to know whether the medication is giving them effect or not, whether they have side effects of that medication. So we follow up, and then we realize, okay, there are 3 types of patients. The first type is that the dose works fine for most patients, meaning that they have the effect of the dose, it treat the disease or it manage the disease, and the patient does not have side effect. So that is the best, okay, because the dose is fine. But there are also some patients in which the dose seems to be too high, meaning that the dose, the drug is giving them side effects because of the high level of the drug in the body. And there is also another group of patients in which the dose is not enough, meaning that it's not working. They need more of that medication because all of them are given the standard dose. Okay, so this is the problem of giving traditional way of prescription of medicine, because we use the standard dose for everyone, where else actually we ourselves as a human, we have genetic variation. Okay, all of us varies. So that also includes our response to the medication. Okay, our response to the medication, meaning that how fast we metabolize that medication. Because all of that medication that we take, all the drug that we take, it will be metabolized by our body because our body will automatically want to get rid of the foreign material, right? So our body will metabolize. So the drug should be, the dose that are given should be able to have a certain, at least certain concentration in which it become useful or it will give effect. Okay, so the variation in the genes that are going to affect this metabolism, for example, and also other genes, it will determine whether this patient is going to receive standard dose or some patients who need to receive lower dose and some patient needs higher dose. Okay, so this is actually the concept of precision medicine, because we look at the genetic profile of the patient, genetic variation, in which affecting how they will respond to the medication. Okay, so if possible, we would like to stratify. In the beginning, before we give the patient medication, we want to stratify them into, okay, this group, you get the normal dose. So this group with the fast metabolizer, you will get a higher dose, for example. And then the group with the poor metabolizer, they will get a lower dose. Okay. All right. So is everything okay so far? Did you get that point? Just give me the thumbs up if you are okay, if you understand that part. Yes, Anna, you raise your hand.
No, sorry, doctor. It was good. It was good. Thank you.
Okay, all right. Okay, that's good, huh? Okay. Okay, just put in the chat box if you have question, or you can also unmute your mic if you want to ask anything, yeah? Okay, so traditional medicine, same treatment for all. This is just an example as well. Cancer patients with colon cancer receive the same therapy even though they have different biomarker. Okay. This is the targeted therapy for chemotherapy. And we already have one or two, I think, example of precision or targeted therapy for chemo, in which we already have an information that if the person have a marker, if the patient have a marker, in which this one, yeah, biomarker, if they have that biomarker, they would likely to be responding to this type of medication instead of another type of medication. So that's how we use that as a personalized medicine or precision medicine. Okay, it's also the same. Okay, so the current treatment approach, which is the conventional type of approach, as I mentioned, it is based on clinical trial or large cohort studies and one size fits all approach. If you look at the product leaflet, they say that, okay, for adults 18 years and above, the initial dose would be 20 milligram once daily. So that is the standard one size fits all approach, okay, as I mentioned before. And it does not guarantee the safety profile of the drug, and it does not guarantee the effectiveness for all patients, okay? And this is according to the Precision Medicine Initiative. Precision medicine is an emerging approach of disease treatment and prevention that takes into account individual variability in genes, environment, and lifestyle for each patient, okay? And also another factor that we need to consider, it is not only genetic, but there are also other things as well that might affect the efficacy or the safety of that medication. For example, their age, themselves. For example, for older age patient, maybe another selection of drug is required as compared to another one. So that would be also considered. Okay, patient preference, mobility level, community resources, pre-existing condition. Okay, that would be another part lah for that. But for this purpose of pharmacogenomics, we are looking at the genetic variation. Okay. So why precision medicine is a better approach? It will treat the patient, not just the disease. because we look at patient's individual genetic profile, okay? And we take into account individual differences, predict susceptibility and risk factor, reduce cost in a long run because, for example, in the beginning, you give the patient with a higher dose of a drug than the one that the patient need. And then the patient develop side effects or toxicity. And then the patient needs to be treated in the hospital because of that side effect. So that also requires additional cost to the treatment of that patient. Whereas another approach, if you actually look at their genetic profile and you know already this patient needs to be given certain dose and you give that dose and the patient do not have that side effect, and it will cause, the cost is actually less because there's less complication, okay? And we are able to stratify the genotype and also phenotype diseases. Okay, so these are the areas within precision medicine research. We have genomics, transcriptomics, proteomics, metabolomics, and epigenomics. Okay, so right now, if we are talking about pharmacogenetics, pharmacogenomics is part of the genomics. Transcriptomics, I think you are more knowledgeable on this part as compared to me. So this one is areas that are also being explored. Okay, but the one that we have now is pharmacogenomics that are slowly being implemented in Malaysia. So the definition, pharmacogenomics is study of variations of DNA and RNA characteristics as related to drug response. So that's similar to what I have been explaining before. What is the difference between pharmacogenetics and pharmacogenomics? Okay, pharmacogenetics is usually we are referring to only one gene, for example, the genetic variations within this gene and the effect of the drug response of, for example, anti-diabetic medication. So that's pharmacogenetics. But pharmacogenomics is broader term regarding the study or the science of looking at the genetic attributes or the whole genome of the person. Okay, we use it interchangeably between pharmacogenetics and pharmacogenomics. Sometimes I refer as pharmacogenetics, sometimes I refer as pharmacogenomics. It means the same, but pharmacogenetics is more like a smaller scope in which we look at the certain genes and with a certain medication, whereas pharmacogenomics is more like a genome, the whole genome of the patient, what are the multiple genes that are affecting the drug response, okay? Okay, I'm not sure whether you know, you have a understanding or knowledge about polymorphism or mutation before this. Do you know about the polymorphism already? If you have, then I can go a bit faster on this. Do you have that? Do you know about polymorphism? Genetic polymorphism? You have that information before? Yes, you understand about it already. Okay, then we can go a bit faster. So polymorphism, genetic polymorphism is when there is a genetic variation in more than 1% of the population, meaning that it can occur uh, very, very commonly, in which if you have 100 of your sample or subject, like 20% of them have this type of genetic variation, whereas the rest 80% have the wild type, for example. Okay, or 5% within your subject of 100 subjects have that genetic variation that causing slower metabolism of drug A. As compared to the rest, 95% has a normal. Okay, so we can still call that as genetic polymorphism because there is a variation in our genetic profile. If it's more than 1%, then we call it as genetic polymorphism. Mutation occurs in less than 1%, it's rare, and usually it is related to diseases, okay, rare diseases or genetic diseases, genetic disorders. Okay, the type of genetic variation, the important ones related to pharmacogenomics are the SNPs, okay, single nucleotide polymorphism, and also insertion deletion. Okay, for the single nucleotide polymorphism, it is very common. It occurs at a single nucleotide. Okay, so this is, for example, this is the reference allele, or the majority of the population have this, AAT, CGC, GTAC, right? So, but for those who have this genetic variation, the C is substituted by T. So it is only single nucleotide variation or polymorphism. So we call it as SNP. For example, here, for individual one, we have 2 copies of allele, right? So copy 1, the patient have T in the first strand, and the second allele, the patient has C. So the genotype here is TC. Whereas the second individual, the first allele, the patient has C, and then the second allele, the patient also has C, then the genotype is CC, okay? So this is what we call as genotype. How we read the genotype, okay? It's either TT, TC, or CC. So SNP occurs every 100 to 300 bases along the 3 billion base human genome. So there can be like 30 to 30 million, 10 to 30 million SNP. So that's that's a lot, right? But then not all are actually functional, meaning that not all are actually important clinically. So most of it occurs random by chance, and it does not affect the medication response. So we are looking at the genetic variation that are significantly affecting the clinical response. Okay, this is also the diagram to explain how do you relate your gene and your medication, the pharmaco part and the genetic part, okay? So as you know, everything comes from the genes, right? All the proteins, the enzymes that are working in our body comes from the gene that encodes the activity and also the expression of that protein or the enzyme. So we are looking at the genetic variation of the genes that are encoding for these parameters. So we have PK/PD. So PK is pharmacokinetic of the medication. PD is pharmacodynamic of the medication. So pharmacokinetic, it relates to how the body is going to, how the body respond to the medication. For example, when you take the medication will be absorbed first in our body, and then it will be distributed throughout the body, so that it will give effect. And then it will be metabolized because our body wants to get rid of that medication, and it will be eliminated or excreted. So all of this process, there are proteins, enzymes that are involved. For example, for absorption, there is a protein that helps with the absorption and the distribution. We have the albumin that can bind to the medication, and it will help with the distribution, for example, and metabolic enzyme, which is very important for pharmacogenetics. So this is where the variation occurs more, okay, at the metabolic enzyme. So genetic variation that occurs in the gene that is encoding for the metabolic enzyme, this is going to affect the metabolism of the drug, okay? And whereas for the pharmacodynamic, it relates to how the drug is giving the response, giving the effect. For example, at the mechanism, for example, the mechanism of action. For example, if the drug for antidepressants, it will act at the serotonin receptor, for example. So this receptor, if there are genetic variation, that in the gene that is encoding for this serotonin receptor, so this is going to affect the response of the drug. Okay, so it is related to the genetic variation occurs in the genes that are encoding for this pharmacokinetic or pharmacodynamic parameter. Okay, so I hope it's okay for now. So this is the example. You don't need to actually remember or what. It's just an example to show you that there are a lot of metabolic enzymes that are involved in the drug metabolism. And many of these enzymes are polymorphic, meaning that they have a lot of genetic variation or genetic polymorphism. Okay, but we will only look at some example later on during our discussion. So how do we actually relate the genotype, genetic variation, with the phenotype? So phenotype is what is being expressed. For example, this person is a poor metabolizer. But then how do you relate that with the genotype itself? Okay, so in pharmacogenomics, we have the guideline from the Clinical Pharmacogenetics Implementation Consortium, CPIC. So this is from the Pharmacogenomics Research Network. So this CPIC group, they have published many guidelines for the pharmacogenetic implementation. So they have they did the standardization of the phenotype. For example, you can see here for CYP2C19, for example. Let me take here. Just look at this bottom part only. For example, of phenotype of ultra-rapid metabolizer for CYP2C19, if the patient have CYP2C19 star 17 star 17, then the patient will be categorized into ultra-rapid metabolizer. So CYP2C19 is one example of an enzyme, metabolic enzyme. So star 17, this would be the allele. Okay, the two alleles lah. Okay, one because each person have two allele, right? So if the person have a combination of star 17 and star 17, this patient is having ultra-rapid metabolizer for this enzyme, CYP2C19. And there are also the classification for rapid metabolizer, normal metabolizer, intermediate, and poor metabolizer. Okay. For example, poor metabolizer, CYP2C19 star 2. So if you can see each of these genotype, it will affect the phenotype, whether ultra-rapid metabolizer, normal metabolizer, or poor metabolizer. So we are concerned if the patient has a phenotype of poor metabolizer or ultra rapid metabolizer, because this is going to affect the medication, how much of the medication will be metabolized and how much will is the concentration at the end in the patient's body in which going to give the effect of the medication. Okay. So this is also another example. This is fine. Okay, so if we are talking about pharmacogenetics and also maybe other part of genetic as well, ethnicity is very important because our population, for example, Malaysian population might be different from Caucasian. Asian different with Caucasian, maybe Asian different with African American, for example. So if you can see here, the population frequency of this enzyme. So this is the example of three major metabolic enzymes, CYP2C9, CYP2C19, CYP2D6. And these are the phenotype, as I mentioned before, like, right? We have poor, intermediate is normal, ultra rapid is the person who will rapidly metabolize more than the normal. So if you look at here, CYP2C19 poor metabolizer for Asians is 18 to 23%, as compared to the blacks and whites, only 5%. So you can imagine if the clinical trials that are being done among Caucasian, in which their population frequency for this poor metabolizer is only 5%, then they might miss that person who have this poor metabolizer. They might just be an outlier from that pool of subjects that they recruited. Whereas in our population, Asian population, 23% have this poor metabolizer, in which they cannot metabolize effectively and the concentration of the drug is higher, they might develop side effect because of the overdose. Okay, so you see the importance of looking at the population frequency to know whether our population is going to be relevant or not to test for this genotype. Okay, and also the same for CYP2D6 ultra rapid metabolizer. It is up to 21% in Asian population as compared to whites and the blacks. Okay, you can see more in Asian, those who have ultra rapid metabolizer for CYP2D6. And what does it causing? It will cause the metabolism of certain medication to be more rapid. So there will be a lower concentration of the drug in the body, in which the patient might not get the effect that we want. Okay, so that will be the implication. So in the US FDA, they already have this table of pharmacogenetics association in the data support for the management, meaning that all the drugs that are newly marketed, because all the medication needs to register with US FDA for the approval. Once FDA approve, only then they can market the drug. But FDA has now already request for the pharmacogenetic data, meaning that they ask the company who develop, the pharmaceutical company who develop that drug, they ask that company to do the pharmacogenetic testing to see whether this medication is going to be affected by that phenotype or not. It's either CYP2D6 or CYP2C19 or CYP2C9. So this is the table that they have compiled, meaning that all of this medication they already included in the medication leaflet. So this is the pharmacogenetic data for this drug. So patients with poor metabolizer for CYP2D6, you need to take a higher dose. Lower dose, for example. So it is already within the leaflet. Okay, so that is how we implement that pharmacogenetics. So this is an example of the card. This is called the pharmacogenetic panel card in the Netherlands. So actually all people or all normal, not normal, all of the public, I mean the public can actually check for their pharmacogenetic panel. They can send their sample to the lab that are doing this testing, and they can already have their data. They can keep their data in this kind of card. For example, you see here which gene or which enzyme and what would be the genotype and what would be the phenotype. Okay, are they poor metabolizer or are they ultra rapid metabolizer or normal for this enzyme? And the patient, they can keep the card, and whenever they require any medication to be given, then they can use this data. They give that to the doctor or the pharmacist, and the doctor and the pharmacist should be able to use this information for their for the better choice of medication or the dose. Okay, so that would be the ultimate goal that we want in Malaysia, but not yet being implemented in Malaysia. So this is the card for the HLA, star 1301 and star 5801 for the for the prevention of adverse drug reaction, because some medication, if the patient take it, the patient might develop the the rash, very severe rash, Steven Johnson syndrome, for example. And this is because of that medication, and we do not really know who is going to get that adverse reaction. It is totally, there is no indication beforehand who is going to get that disease. So that's why we need to test first before we give that patient this medication. So this would be the card to prevent that adverse reaction. We test first, and then we note. So this is from Thailand actually. So they take note, this patient have this allele is very risky for this severe type of skin allergy. So this patient cannot be given, for example here, Dapsone, one of the drug, the patient cannot be given Dapsone or allopurinol. So please use another alternative or another drug. So that's how they implement that. Okay, I think this one is a bit, yeah. So this is just to show you the example of a pharmacogenetic clinic in Bangkok, the nearest to us in from Malaysia. The nearest would be the Bangkok and the Thailand, because Thailand, they have a very good initiative of the personalized medicine initiative, in which they already have the service of pharmacogenetics, pharmacogenomics clinic in the hospital. This is just an example. And they run the pharmacogenetic tests at the hospital to help with the management or the drug choice of the patient in that hospital. Okay. Okay, this is just the example of the direction of the pharmacogenomics, whether you test point of care or you test preemptive. Okay, point of care is when the person needs to be given the drug and then you check whether this patient is having poor metabolizer or ultra-rapid metabolizer, and then we give according to the dose that is relevant to that patient. Whereas preemptive is when the patient is not yet being planned for the medication, but the patient wants to test first. So this is the example is from the card, pharmacogenetic card that I showed before from the Netherlands. This is when they do the preemptive. They check first, and then they get the card, they keep it. And if anytime soon they are having the disease and they need to be given medication, then they will use the card. So that is preemptive testing. Okay. Okay. I think this one is a bit advanced for you. Okay, I think that's all as an introduction for pharmacogenomics and precision medicine. So any question regarding the topic? Is everything clear? Okay ya, EN no doctor. No doctor tu maksudnya apa? Do you mean it's not clear or you mean it is no questions? Okay, okay, all right, no question. Okay. How about the others? Right, Gao, Song.
Okay, Victor, thank you.
Okay ya, Tapa. Okay ya. Okay, all right. Okay, so I will share with you. I think first maybe we can do a very short quiz. I will send you the link. Wait, yeah. Okay, wait, yeah. Okay, I will share the. Okay, can you see the screen? Can you see the quizzes? Can you see this?
Yes, Victor. Yes, Victor.
Okay, can you try to log in? Enter this code. Okay, join myquiz.com. Enter the join code. Okay, we start. Okay, I think only 2 of you have already completed. What happened to I don't know which one of you haven't started because you don't put your actual name. Let me know which one is still okay. Who is the last one who have not yet started? I'm not sure which one of you is this. Except Rat, except Sana. One of you haven't started. So we will look at the answers shortly, yeah. Song is not in WebEx anymore. Is she disconnected? Maybe we have to. Yeah, not sure it's where at. Okay. Okay, we're still waiting for 2 of you to complete. Okay, another one to complete. Okay. Who is number 4 here? I cannot read your I cannot read these letters. Which one of you can you complete the questions? So then we can have a look at the answer. So we have Pushpa. Who is Pushpa? Who is Pushpa? Okay, shall we look at the answers now? Okay, alright. So you can see this slide, right? Sorry, no, not slide. You can see my screen here, right? We can have a look at each question. Okay, I think this one all of you got correct. That's very good. What is personalized medicine? In tailoring medical treatment to the individual patient. How does personalized medicine differ from traditional? Okay, this is very easy, right? stop sharing first. Okay, so can you hear my voice clearly now? Can you hear my voice? No. Yes, that okay, okay, okay. Actually, I did not share the audio. Let me know if you still have problem, yeah, hearing me. Okay, so second question is okay, yeah, everyone got correct, very good. Third question, what are the benefits? One incorrect. More effective treatment, reduce side effect, and better patient outcome. Okay. Number four, all correct. Yes, that's very good. What are the challenges? Okay, this is I skipped this part actually, but yeah, it's good that you answer correctly. Lack of public interest, low availability, minimal impact, ethical consideration, data privacy concern, high cost. So these are actually the concern now that are the challenges of implementing personalized medicine because of that ethical consideration, data privacy, and also the cost of that genetic testing. What is pharmacogenomics? How the study of genes affect a person's response to drugs. Okay, how does pharmacogenomics impact drug development, identifying genetic variation? Okay, and also the potential of application, very good. Personalized medicine, drug development, ethical consideration, only one got incorrect. Why the patients are actually concerned ethically is that they will be discriminated based on their genetic results. Because if, for example, they want to claim from the company, from insurance company, insurance might not favor those who have this kind of genetic variation, for example, to cover for the cost of their medicine. So that would be the concern. And also, genetic information might be leaked to that insurance company, so that might affect the patient as well. This one example that has been influenced, this one I did not cover actually. So it is warfarin. Warfarin would be one of the example of drug that are being influenced by pharmacogenomics. Okay. All right. So we'll move to the next activity, which is for the tutorial. It can be yeah. We can do that briefly, but first, you need to watch a video, okay, YouTube video. If you can go to your eLearn, so while you are at your eLearn, can you mark your attendance and you go to the link, the YouTube link that I have provided. Okay, let me share here. Where did I share it? Okay, so this is the eLearn. If you go log into your eLearn now, you go to this chapter 4. Okay, chapter 4. So the first one was the one from Dr. Nurul Hasanah, right? But here is the one that is starting for the pharmacogenomics. This is the WebEx link. So if you go to this attendance, click your attendance, mark your attendance, and you go to this tutorial material. So you open this this YouTube link, watch this video, and then This is your task. Okay, watch that video and you list 3 key messages that you can grab from the video and how can genetic variations influence an individual response to the medication. Use the example that you can get from the video. Okay, so this is individual task, so you can write down somewhere or you can put in the chat box for us to discuss later. So I will give you around 10 minutes, okay? The video is actually 7 minutes, so maybe like 15 minutes, okay? So if you can complete that by 10:40, okay? So 10:40, we will discuss. All right, let me know if you need any help, just let me know in the chat box, okay? Okay, Sana, in your page, you cannot see any links or videos. Okay, okay, okay. I can put the link of the video in the chat box, okay? I think this is the one. Let me check first. I think this is the YouTube that we want. Yes, so I will put this one. So remember to also mark your attendance. Okay, I opened it until 12 o'clock.
It is day 3. Two days after my surgery. My biggest fear was that I would have a bad reaction to the pain medication, and I have not had one.
Pharmacogenomics, which very simply stated is the genetic influence on your drug response. What we envision in the future and what we're doing now, so the future is now, is measure your genetics for the genetics that we know impact drugs in specific ways, and then figure out if drugs are likely to work for you or not work, or should be as expected.
Human-Wide is a pilot that we are conducting in a primary care clinic in Santa Clara. We at that clinic have also implemented a team-based care model, which we think is going to help us transform what we're doing in primary care. The focus of Human-Wide is to consider how can we leverage the best of the art and science of medicine that we have at Stanford and across the country and the world. Technology, genomics, diagnostics, how do we leverage that so that we are focusing on prevention and proactive care to prevent disease before it strikes?
The issue that I have
is that when I'm lying down in bed, I can't breathe through my nose, primarily because there's not enough room in the nasal passages, and also because my nostrils collapse when I breathe in. The surgery that I'm going to have will create more space inside the nasal passages and will also strengthen the structure of the nostrils so that they don't collapse when I breathe.
I take vitamin C, magnesium. Vitamin D.
Great.
And I take flaxseed oil.
We're going to start with this. This is a pharmacogenomics testing kit. So for this kit, we're just going to collect some samples from your inner cheek.
Pharmacogenomics is the study of how your genetics, your ancestry, your parents, your grandparents, how that affects your response to drugs. Not everybody responds to drugs in the same way. That's kind of a natural idea. But why is that? And it has to do with what you're eating, what diseases you have, but it has a big part to do with your genetic background. So how you respond to drugs is inherited, just like many other things, like how tall you are, what color your eyes are, perhaps what diseases you might be at risk for. So what we want to do is we want to check people's DNA and then give them a report of which drugs are likely to work and which drugs they maybe should stay away from because they're either not going to work or the side effects will not be tolerable. That's in a nutshell what we're trying to do. Predict drug response by making precise measurements of the genome.
Hi, good morning. Today is the 4th of May. We plan to get out to go to Los Angeles for a few days. My blood pressure is good. My heartburn much better because I changed my medicine. So everything is fine. Talk to you later.
Eddie's pharmacogenomics results were remarkable for a couple of things. So one was his cholesterol-lowering medication. We were able to halve the dose of his statin, which is significant because for Eddie, his primary medical concern is his low back pain and his muscle aches. And we do know that statins can cause muscle aches.
Nice to see you.
You too.
I'm Dr. Altman. Welcome
Debbie.
to the Pharmacogenomics Clinic.
Thank you.
In this clinic, though, we're focusing on your response to drug, and we've learned that we can find small differences in the DNA that might make you, for example, metabolize a drug more quickly and get rid of it, so it's not actually in your bloodstream as long as it might be for somebody else. Or it might work better for you than for other people because of a little difference in your DNA.
Well, specifically, I'm concerned about narcotic pain medications because I'm going to be having surgery, and the surgeon has strongly recommended that I take narcotic pain meds after my surgery for the pain.
Have you had bad experiences previously?
Primarily, I get really dizzy and disoriented, sort of drunk and, high.
Wow.
And I don't have any pain relief, so I just feel awful.
That's even worse.
Yeah.
So you're getting all the side effects, but not any of the benefits.
And then I itch. I itch terribly all over my
Very
everything.
common. There might be even drugs that have not even been released on the market yet that will be impacted by some of these genetic differences, and so it would be useful even going into the future to know about your status for some of these enzymes. So the first one that I'm going to highlight is this enzyme CYP2D6. So you're a slow metabolizer for this enzyme, but the important thing is that this enzyme is responsible for metabolizing like 50 or 100 drugs, which means right off the bat, there are 50 or 100 drugs that I might recommend you get a lower dose of or less frequently, including some of these opioid narcotics that you were talking about. I think that what we'll recommend is opioid medications that don't get metabolized by this enzyme, so it's totally taken off the table.
Today is day 5, Tuesday. My surgery was on Friday. I'm not feeling very much pain right now. I didn't have any of the foggy headedness that I considered a negative side effect.
If we can bring pharmacogenomics to the front lines of medicine, I think we have a better chance of managing health instead of managing disease. And so that's where precision health is a powerful idea, where we're trying to keep people out of the system by giving them the minimum medication at the right time and not have their diseases progress, get worse, and become chronic diseases.
Okay, I think we should start to recap what we have learned from the video. Sekejap ya, So maybe I can get. Oh, so where is Song? Song is not. Yeah, Song is here already. I thought you already disconnected somehow. Okay, so Song has already put in the chat box what are the three key messages that you can get from this video, right? Song, would you like to explain yourself? You can unmute yourself. Yeah, Song. Yeah. Song, are you saying something? Oh, sorry. I got the laptop muted. Okay. Did you say something? Song? Sorry. Do you want to say something, Song?
No, I don't want to say something.
No, you don't. Because you put your questions already and your answers already here, right? Okay, can use to personalize medication, reduce side effect, reduce adverse reaction, enhance the efficacy. Okay, but what I mean is that the key messages here you would like to reflect on the examples of the cases in that video. Okay, we have two cases, Debbie and I forgot actually the name. Debbie and also Eddie, right? So with Debbie's case, she has to undergo no surgery, and then she do the pharmacogenetic testing to see whether the analgesic or whether the drug that are being used for the surgery is going to be useful or not. Otherwise, she will not get the effect. And then, for example, for analgesics, if she did not get the effect that is needed, then she will have to endure with the pain after the surgery, right? So they run the test for the opioids pharmacogenetics to see whether she is actually going to be going to metabolize opioid faster or not. Okay, so that is the importance, so that she can get the optimum dose of that opioids as the analgesic after the surgery. So you can imagine if she was given the opioids and then she actually have, for example, for in the case of codeine needs to be metabolized by the CYP2D6 into morphine to get the higher analgesic effect. And if she is a poor metabolizer or if she is a rapid metabolizer, then she will convert codeine more rapidly into morphine, and then she would have an overdose of that morphine, of that codeine. Okay, the other way around, if she is a poor metabolizer, she cannot turn codeine into morphine, so she is more likely to be underdosed. Okay, so that is the importance of that pharmacogenetics in analgesics. And Eddie is about which medication for Eddie? So I can see Sana managing health and life better, less side effect. Okay, yes, inheritance, genomics. drug metabolism affected by the enzyme produce, analyze, and work on the targeted. Okay, for example. Okay, Sana, I think some of your sentences are missing here.
Yes, doctor. When I heard we are doing the orally, so I just put the thing that I just wrote that time.
Okay, yeah.
So it's the same thing as all my friends, they mentioned that thing. So it's depends to the genomic, how's the variation affect the drug responses, because our genomic, it's affecting our enzymes, our receptors in the cells and everything. So that one is just making the differences how we are responding to the drugs and any kind of the medication due to our genomics.
Okay, yeah. Thank you, Sana. Very good. Okay, thank you. Right, enable personalized medicine based on individual genetic profile and reduce side effects. Yes, increase medication efficacy. Okay. Yen, understanding, allow medication to be given to the right people at the right time and the right place. Yes, very good. Minimizing adverse side effects. Yes, providing better future outlook for the patient. Better future outlook, it might be a bit general, but then maybe you are talking about the patient's quality of life, if the medication are being managed, if the disease or treatment is being managed properly in the beginning, so it will create more sense of trust of the patient towards the treatment itself, and it will encourage the patient to be more compliant or adherent to their medication. So they're more likely to take their medication because it's working, right? For example, if the patient are getting less than they need and then they do not get the effect, and then they might not trust the medication, they might not trust the treatment. So it might affect their adherence. Okay, Gao, the core in the body's response to the drug, try to minimize inappropriate drug use. Prevention should be done in advance rather than treatment. Okay, the core is body's response to the drug. Body's response to the drug would be the pharmacokinetic part. Okay, pharmacokinetic part. But then the important message here is actually the genetic variation part. How genetic profile is going to help improve the drug treatment that we have now, because now we only based on the standard dose, right? That is the current treatment, the conventional treatment. But then how are we going to improve the treatment through the personalized medicine or precision medicine? The key word here, the key message is actually the genetic variation or the genetic profile. Okay, so you need to add that genetic profile in your answer, Gao. Okay. Tapa, everyone responds to the drug differently. Yes, knowledge on the gene can help in the dose adjustment. Yes, that's correct. Based on the previous lecture, right? How the genotype of the patient is going to be interpreted into phenotype. That phenotype can be ultra rapid metabolizer or metabolizer that would affect the dose that are needed by the patient, and we can adjust the dose. Okay? The genes can be used to prevent and treat diseases individually. Okay, all right. I hope you understand based on the lecture before, and also the video that shows the example, right? And as you can see in the US, they also have pharmacogenomics clinic that can help do the test, the genetic test specific for the pharmacogenetics. For example, metabolic enzymes and transporter proteins, and also receptor. Okay, so that would be more specific towards the enzymes, proteins, the genes that are related to the medication. Where else maybe in the genetic center, genomic medicine center, for example, they have more towards the medical, rare diseases or cancer, targeted cancer. So pharmacogenetic is more towards the enzymes, okay, and also proteins. Okay, I think that would be for the tutorial session. So we shall have a short break later, but then I would need to brief you on the task for the discussion. Okay, you are seeing this, right? So we have a discussion later. So if you can go to your e-learn, okay, this is your e-learn. You go to chapter 4 as usual, and you can see here the discussion task. You can click this page. So I put here a link to Padlet. Okay, so this is a Padlet link. So if you click there, you are being transferred to this link, to this website. So this is Padlet, in which I put the task for the discussion session. So your general instruction is here: explore the application of pharmacogenomics in personalized medicine in a given area. So I have topic 1, pharmacogenomics in diabetes. Topic 2, pharmacogenetics in cardiovascular disease. Topic 3, pharmacogenetics in psychiatry. So for each topic, I give article. So you need to download this article and evaluate how genetic variations impact the drug response and treatment outcome. Discuss the role in optimizing therapy selection and minimizing adverse effect. So before this, our task is a bit general, okay? Because you have understand the concept and the importance, the role. Now we want the discussion more regarding the specific application or example, okay? And here, you are 6 of you, right? So you have to pick your pair. The task will be done in pairs. Okay, so Yen already with Sana. Okay, that's quick. Topic 1. So who is going to take topic 2? You can put here in the comment. Okay, pick your pairs. Download this and you can prepare your PowerPoint slide, one slide only for each pair, each topic, and you can present later. Okay, so maximum would be 10 minutes or maybe less lah, okay, for each group to present. Maybe like 8 minutes for you to present your discussion points that you have with your pair, okay? So you can upload your PDF slide as well underneath this. So I think I have opened this for you to edit. So you can click here, for example, and you can upload your PowerPoint slide here as well so that we can all see. Okay, later on when you want to present, you can share your screen and you can present later. Okay, yeah. Can I have the other 2 pairs? Who is going to chat? Where is it? So, topic 2, Rad, and who is going to take topic 2?
Oh, I want to take topic 2.
Who is that song, right?
Yes.
Yeah.
So, topic 2, Rad, and and Song. So I will open the breakout room later so that you can do a discussion. So topic 3 would be Gao and Papa. Is it okay? Okay. Okay, now. All right. So I will try to open the breakout room. But first, let me recap on the timing. You have a break, 10:15 until 11. You can start your discussion. 11 until 11:30. But if you finish early, you can also let me know in the chat box. So 11:30 until 12, discussion in which you need to present each group. Each of you need to present so that I can evaluate on your on the rubric, based on the rubric. I put the rubric as well here, okay? The component of assessment. This would be the component of assessment, okay? Separate material concept into component parts and distinguish between facts and inference. Critical thinking, ability to expand thinking skills, analyze, evaluate, discussion, okay? So this would be the cognitive level C4 of discussion, okay? So we will resume yeah, 11:30, okay? And see you later. I will open breakout room so that you can go into your room to discuss. Wait here, I will stop this one. Number of breakout room, 3.
Hi, doctor.
Yeah,
We can only prepare one slide, right?
yeah, one slide for each topic.
Okay.
Okay, yeah, you can take turns presenting later. All right, I will create the breakout room. You can go in according to your room, yeah? Yeah, I need to, okay, let me assign you Yi-En and Yi-En and Sana on the first, yes. Gao and Tapa, okay, Song and Rad. Okay.